Hi, everyone. Welcome to IBD Insider patient updates from the 2024 Crohn's and Colitis Congress. My name is Maggie Tretton. I was diagnosed with Crohn's disease at the age of 11. I became a nurse because of it, and I also became a patient advocate who shares their IBD story online. So I'm going to hand it over to my good friend, Aaron Blocker.
And my name is Aaron Blocker. I'm excited to be here. I have Crohn's disease. I was diagnosed when I was 17, and that has really pushed my life into biomedical research and patient advocacy work. So it's really great to be here. I'm excited to see everybody. So last month, the Crohn's and Colitis Foundation and the American Gastroenterological Association hosted the annual Crohn's and Colitis Congress. This is the premier meeting for IBD, or inflammatory bowel disease. More than 1,600 IBD health professionals and researchers came together to discuss the latest research about Crohn's disease and ulcerative colitis. And tonight, we're going to take that information that was presented at the Congress and bringing it to you during this IBD Insider meeting so that you can have the most up-to-date understanding of your disease.
Aaron and I were both patient reporters at Congress. Our role was to attend as many sessions as we could pack into our day and disseminate the information learned through social media to our IBD communities. We are excited to share with you our key learnings from Congress, and then you'll hear presentations from some of our expert clinicians about their highlights from Congress, including the latest in IBD treatments and the future of IBD care.
So here are a few things to keep in mind as we go through tonight's program. The information shared here, it is meant to be for educational purposes and should not replace any advice or guidance from your own healthcare professional. And the program will be recorded and posted on the IBD Insider website. You can find that at www.crohnsandcolitisfoundation.org/IBD Insider. And everyone who has registered for this program, they will receive a link with the recording next week.
We want this to be as interactive and engaging for you, so we encourage you to submit your questions in the Q&A box, which can be found at the lower portion of your screen. Following our expert presentations, I will moderate a Q&A session with all of our panelists, and we'll address as many questions as we have time for. On behalf of the Crohn's and Colitis Foundation and the American Gastroenterological Association, thank you so much for joining tonight. I'm going to be sharing some of my key learnings, and then Aaron will be sharing some of his shortly. So if we can, yeah, perfect. So like I said, my name is Maggie Tretton. I share a lot about my IBD story online through a channel called Let's Talk IBD, and I also became a nurse in 2016. If we can just go to the next one. These are my disclosures here. Okay, so there were a number of things that we learned in these jam-packed days, but there were definitely a few overarching themes that I took away with me. The first, and I think the one that's probably going to be repeated every year forward, is going to be new medications. When I was first diagnosed, there was only, it felt like a couple medications, and I was so fearful of running out of options. That is not the case today, thank goodness. You can check out on CCF's website the medication guide to see all of the new ones available, but they're improving in a number of ways and the number available. The first is how we take them. I think a lot of us have probably dealt with injection talks and infusion talks, and that can be a really scary conversation. But now a lot of the medications are becoming oral, like the small molecule ones and the JAK inhibitors. So that is fantastic. I know a lot of patients do better with oral medication. They're also becoming more specific to the patient. We're really looking at the disease progression for each individual and targeting medications that will hopefully work best for them. So that was really neat. You're not just going down a line of medications, because that's how it's always been progression-wise. They're also becoming more cost effective, which is really neat. Talking about biosimilars, I know it's a really big topic of conversation in the IBD community, and it can be a little nerve-wracking to start a biosimilar if you're on a primary med. But this is, they're doing so much research on it, and making sure that these biosimilars act just like the primary medication. So it really was encouraging to hear about that research. And the best part, it's cheaper. I know we get a lot of sticker shock when we see how much some of these medications cost. And I think the best part is that they're working faster. I know a lot of patients who wind up going into flares and they switch medications and they're kind of twiddling their thumbs, waiting for the drug to kick in. So it's great to hear that they're working faster. The next thing that I really took away was surgery, and this is something that's personally affected my life quite a bit and given me a ton of relief. And so surgery was starting to be reframed as an option rather than a last resort, which is what I think a lot of people think about surgery. So that was really neat to hear. I always wonder, what would it have been like if I used surgery as a little bit more proactively? Would I have had a better outcome? Um, and they're also really recognizing the unique needs of patients, especially those who go through different surgeries. Anatomically, we're a little bit different. And there are some needs that haven't been recognized in the past, things like pelvic floor therapy, and dietary changes. There's a number of things. The next one that I took away was Camp Oasis. This is something very close to my heart as I attended Camp Oasis as a child. Kids that attend are reporting that they've learned more about their disease. They're improving their knowledge on what medications they take, what they're named. They're also feeling more supported leaving camp, and they make lifelong friendships. They expect that they'll stay in touch with some of the people that they've met, and all of that I already knew going to Crohn's Colitis Congress. I was totally aware of that, but to have official reportings on it, that's very neat to hear. And finally, the power of Crohn's and Colitis Congress. I listed here the information pipeline because I had personally worked as a bedside GI nurse, and I would see some of the healthcare professionals go to different conferences, gather knowledge, bring it back to our unit, and we would implement it, and we would see real change in our patients. It was really neat being on the other side of that to see where that knowledge came from in the first place. It was just super cool to see that. And I was looking at all of the attendees. There were hundreds. I don't know the exact number, but there were hundreds at least. And to know that each one of them were going to go back, they're going to take the information they learned, go back to their workplace and share it with their colleagues was really incredible. So it was really thrilling to feel like I was at the forefront of IBD education and knowledge, and really an honor to be one of the patient reporters sharing it on social media to other patients like myself, alongside Aaron Blocker, who I'm going to hand the floor over to.
Yeah, so if you could go to the next slide, please, that'd be great. So I'm Aaron Blocker, and like I said, I've been diagnosed with Crohn's disease since 2009. And here are my disclosures. I have a master's in biomedical research, and I work in research and data and analytics. And so I was on the basic science track at the Congress conference. So Maggie and I kind of split our time between, she was on the clinical since she's a nurse, and then I was on the basic science track. And what that is that's just the bench work, the lab work, all of that, the stuff that goes into getting treatments and everything to the new updates and all the science. So it was really cool. There was a ton of basic science research, which I personally loved. And so some of the key takeaways that I had, one of the big things that I went to was the gut microbiome research. Probably over the last several years heard about the gut microbiome. There's been a ton of research going into that, trying to figure out, what are these gut bacteria in our bodies doing? We know that in inflammatory bowel disease patients that the gut microbiome makeup is a little different. So they're really studying this to see what we can do with it. So a couple of things that came out of that is, can we use these microbes, these gut bacteria, to our own benefit? Can we figure out what they are doing? Are they making certain molecules that are anti-inflammatory or pro-inflammatory? Can we utilize that and maybe make that into a treatment someday? And so that's the molecules that they're using. So maybe we'll get a treatment one day based off some of these molecules that the gut bacteria are making, which is really cool. The gut-brain axis was a big topic as well, talking about how our gut bacteria influence our brain and how we think and things that we do, which was really, really neat. And then one of the other there was a really big session on remote monitoring, which I find really cool, especially as kind of a patient. So telemedicine has been a big thing that's come up over the last few years, especially throughout the pandemic, where we needed to see our physicians, but needed to be safe about it. So telemedicine became a really big thing over the last 3 years. And it's something that is continuing to be a great thing for patients. And so I was really cool to see all the work that goes into that and the access that it gives to patients. It gives us a lot of access to our physicians in those moments where maybe we can't get to the doctor at that time. Then wearable devices was a topic in this remote monitoring. So a lot of people wear things like a watch that tracks all of your movement and activity. And so there's a lot of research into that. There's a lot of data that you can get from that from patients. So they're trying to see what can we get from that and how can we utilize that to our benefit? How do we use this data that we're already getting, the stuff that we're already getting from our smart devices that are monitoring us all the time? How can we use that to our benefit? And then using AI, so machine learning is huge. I think everybody has heard of artificial intelligence lately. It's probably the biggest topic in most fields at the moment. But so how do we utilize that? How do we figure out how to use this AI and machine learning to help our care for IBD patients? So that's one of the things, like these are things that are very at like the forefront of the science today in general. So as the IBD community, they're trying to really utilize those things that are at the forefront. How do we use that to help patients? And then there was a really cool session on pediatric updates in IBD. There was a growth study that was presented there that was really cool, talking about how utilizing certain medications early on, like biologics early on, can help actually patients grow and get over some of those growth hurdles that pediatric patients have, whether that is their low BMI. We often deal with weight problems as dealing with IBD, usually very skinny, especially in the pediatric patients. And so it was a really cool study. And then the multidisciplinary approach in that there was actually a pediatric rheumatologist who presented at this, and I thought that was really cool to have that multidisciplinary approach to this, because that's what it takes to treat IBD, is a multidisciplinary approach. So to have a pediatric rheumatologist talk about her experience and how the patients that she gets referred to, talking about musculoskeletal problems being the most common extraintestinal manifestation that patients deal with. So she sees a lot of that, like arthritis, and especially in the pediatric population. And then, as Maggie said in hers, the treatments. So there was a lot, even in the basic science, on the treatments that have updated. And there was one of the things that I took away from the session was one of the pediatric GI doctors talked about even the guidelines that we have 5 years ago for treating inflammatory bowel disease are no longer completely up to date because we have so many treatment updates that have happened over the last few years. There's so many new medications and biosimilars and things that even the way that they treat it clinically has changed over the last 5 years, that they're having to constantly update that. And to me, that's very encouraging because we're constantly getting new treatments and new clinical guidelines for patients like us, and they're actively changing that. So my overall takeaway was that the future of IBD is bright. The future of treating the patient, treating this disease is really headed in a direction that is mind-blowing, honestly, because as Maggie said, when she was diagnosed and when I was diagnosed, we had only a couple of treatments available. I mean, it was just a couple of treatments and that was really it. And now there's so many, and they're continuing to update those and get new treatments. It feels like every single year. So especially with biosimilars. So that was my experience after sharing with Maggie. And we said it before, we said to a lot of people that there was so much information in a good way, and that we felt really encouraged after leaving the conference. And so I hope that everybody on the call today found that perspective helpful. Maggie and I were super excited to be the patient reporters at Congress and to be able to have that patient presence there, I think is a really big deal. So it was really an honor for both of us to be able to go to all the sessions and take in all the information. And so we were really excited about that. And I hope that you have taken a little bit away from that. So now I would like to introduce our first featured expert. That is Dr. Kelly Cushing-Dom, who is going to speak on monitoring disease and therapy. So Dr. Cushing is an assistant professor at the University of Michigan. She predominantly cares for patients with inflammatory bowel disease in her clinical practice, and she runs an NIH-funded research program focused on the integration of clinical outcomes and translational research, which to improve the prediction of disease course and therapy response in patients with IBD. She's doing some really cool work for IBD patients. I'm very excited to introduce her. So welcome, Dr. Cushing-Dom.
Thank you so much for the introduction, and I agree, it's a really exciting time in IBD. So we'll be talking in my section a little bit about disease monitoring. It's a big topic. We'll try to cover a good amount in the 15 minutes that we have, but we'll really focus on high-level overview stuff as we move forward. I don't have any financial disclosures. So I've broken this section into 3 areas to talk about. The first one is background and rationale for why we monitor disease activity in IBD. So that's a core concept for us as clinicians. And then I want to spend a little bit of time talking about what are the current tools that we use for monitoring and why are they beneficial. And then finally, the latter part of the talk is sort of the more interesting, think ahead kind of portion of the talk, which is, recognizing where are our limitations and where are opportunities as we look to the future, because we always want to continue to evolve and do a, better and better and better job taking care of our patients. So the one take home point from this slide is that if you have inflammation and it's not controlled, meaning not in remission, there's an increased risk of having disease-related complications. So that can be things like strictures, fistulas, abscesses. Long-term, the risk of malignancy or cancer can go up. And so we want to make sure that we get that inflammation controlled as quickly and efficiently as possible as your clinician. This figure really just emphasizes the point that if we get a patient into a deep remission at 1 year after starting their therapy, that means the scope looks good, you're feeling good, and you're not needing steroids to be in that state, that you're doing much better, much less risk of complications long-term. We can advance. So this slide is really just to drive home the point that there's a lot of different things that we think about in terms of getting control of disease. It can range from making sure we recognize the disease early to making sure that we get fine adjustments in our therapy as we move along. But the one small part of this larger approach that we're going to talk about today is how do we monitor disease? How do we make sure that our drug is working or not working so that we can make a timely decision to move on? We can move forward. So this is an important slide when we talk about disease monitoring. These are our current guidelines called the STRIDE guidelines. You'll commonly hear the words treat to target. And the idea behind this is giving us as clinicians a roadmap. When we have a patient who's got active inflammation, active IBD, how do we move forward and make sure we get them to remission? Because I've told you remission is really important. So the first thing we do as a clinician is we stratify the risk of the patient. So are we talking about severe disease, mild disease, and we make decisions about what the best therapy is for that patient. And then what we need to do is set some targets for ourselves, short-term targets and long-term targets. So when we're talking about short-term targets, we're talking about things like making sure that you as a patient are feeling better, that your symptoms are headed in the right direction, you're on the right trajectory. And then we sort of move into what we call biomarkers. These are ways, non-invasive ways to measure how the inflammation is doing. Is it responding to our therapy? Again, is that trajectory positive? And then finally, what we call our long-term target is going back and looking and making sure that that mucosa has healed, that you're as close back to a normal colon or small intestine as you can be. Okay, we can move on. Okay, so now let's talk about just those 3 points I mentioned: symptoms, biomarkers, and endoscopy, and highlight why they're important. Number 1 is symptoms. So symptoms are always beneficial because it's really important for us to get patients in a state where they feel well, that you're back to having a good quality of life. So we definitely need to use symptoms as a target for ourselves. But what we found through research consistently is that symptoms in isolation are not enough. This is for a variety of reasons. Number 1 is that, and probably the most important, is that symptoms do not always correlate well with disease activity. You may have active disease and have no symptoms. You may have symptoms, but they may not be from IBD. They might be from another GI illness, such as like an irritable bowel or another sort of GI condition that's going on concurrently. So we really need to know, in addition to symptoms, what's going on with objective markers. So one way to do that is called biomarkers, and we'll talk about that in the next few slides. But a take home from this slide is that when you use symptoms and biomarkers together to make treatment decisions, rather than just symptoms alone, you have higher rates of getting to that healing, that mucosal healing, which is what we want long-term to prevent complications. So that's why your provider is going to say, we need some additional data in addition to your symptoms. So I just said biomarkers can be helpful. Let's talk a little bit about 2 common biomarkers that you might see in your monitoring strategy. The first is called a C-reactive protein, or CRP is the abbreviation that's commonly used. CRP is very interesting. It's a protein in the bloodstream. It was actually originally discovered in the 1930s when they were studying pneumococcal infection. That's a type of bacteria that can cause pneumonia. And what you find is that it's actually mostly made in the liver, and it's a response to inflammatory cytokines, which are these proteins that are propagating inflammation for a variety of diseases. So in line with that, it can elevate for a lot of reasons, one of which is inflammation related to IBD, but it can also go up with infections. I told you it was studied for pneumococcal infection, injury, broken bone, for example. There's a lot of reasons you can get a rise in a C-reactive protein. So in summary, what are the positives? Well, it's rapidly rises and falls. So it's really good for us in short-term situations. For example, like when a patient's admitted to the hospital, we want to know what's going on a day-to-day basis in terms of our progress. It's pretty cheap. Most places perform it. So those are all good things. The drawbacks are that it's not specific to the GI tract, as I mentioned. So it can be helpful, but it's not perfect. It's not a perfect measure of what's going on for inflammation. And finally, not all patients are going to make CRP, so it may not be the best marker for everyone. So to supplement that, you might do a calprotectin. That's a very specific GI biomarker. It's obtained from the stool. It's a protein released from immune cells, and it will also elevate with inflammation or infectious conditions. The pros are, again, it's not invasive, which is great. It's got more specificity for the GI tract, and it does a good job associating with clinical relapse and endoscopic healing, which are two important outcomes for us. The negatives are that it does take a few days to come back. It can be a send-out test because it's not universally performed. And again, not all patients are going to necessarily make calprotectin, so it may not be perfect for everybody. And finally, endoscopic monitoring. So this is that colonoscopy, usually at the end of perhaps 6 to 12 months after starting therapy. We want to visually go in and make sure that the inflammation we saw before is as close to remission as possible, ideally perfect remission, because we know that people do better when we achieve that state. There's less hospitalization, less surgery, less need for things like steroids. So that is our end target. Okay, so we've talked about why we monitor. We've talked about what tools we are currently using. But the title of this talk was what needs to happen, right? So the latter portion of our conversation is about recognizing the limitations in the current approach and thinking about how we can move forward and make it better. So here are just some gaps that I identified, not all inclusive necessarily. Number one is there's variability in the timing and the completion of disease activity assessments. We gave a roadmap for where we sort of want to get these targets assessed, but you're not always going to necessarily hit the exact time point for a variety of reasons. Number one might be patient level factors. So there's competing responsibilities, work commitments, childcare commitments. Dropping off the stool sample can be very difficult. You have to have the sample, then go to the lab. It's not a small process. Insurance coverage. I mean, these can be costly tests if they're not covered by insurance, so that can be a limitation. And at the provider level, you obviously only have so many clinic slots. And so if your access is limited, getting those things ordered and completed can be delayed. And then finally, system level factors. So even above the provider is the institution that one works for, and there can be long wait times for colonoscopies. There can be limited staffing, for example, only running a certain amount of rooms every given day based on your staffing capabilities. So those are some things to think about. The next thing to think about is treatments. So as was mentioned, we have a lot of exciting treatments, more treatments now than 5, 10, 15, 20 years ago. But with increasing treatments comes recognizing that they work sometimes on different timeframes. Some are more really gut specific and slower acting, more appropriate for mild or moderate disease, for example. And some might be really fast acting, really important for patients with severe disease in the hospital. But we really have a uniform approach to how we're monitoring, but that might not be necessarily treatment specific, right? We may need to think of more about what mechanism are you on and how does that influence our short and long-term targets. The other thing beyond just the individual treatment you're on is your disease phenotype, right? So how aggressive is the disease? Somebody with mild disease who has a really robust initial response to a therapy may not need as tight monitoring up front. Maybe they're a little bit looser on that monitoring timeline. And somebody with severe disease, maybe on the verge of a colectomy, maybe that's the person where you shorten that monitoring window. You're more aggressive about making sure we're getting into remission very quickly. Okay, so those are just some consideration of limitations. We'll spend the last 5 minutes of this talk just saying, what are the opportunities that we've identified? And there's many that we could talk about, but I focused on 3 for this conversation. One is telemedicine and remote monitoring. The second is clinician-directed point-of-care testing and imaging. And the last is machine learning or artificial intelligence, like was mentioned. So telemedicine was done a little bit, I think, before COVID, but obviously just a huge boom after COVID for a variety of, reasons. We didn't need to see each other face to face. It wasn't safe at the time. And so we really integrated telemedicine into our practice. And so now a lot of us will actually continue doing telemedicine for a variety of reasons, and it can be very beneficial for patients. It can improve access when, for example, you're ill. If you are tied to the bathroom, it is not a great time to try to get into the office, right? It can be very difficult. If you live 5 hours away, it can be very difficult to get to your provider. And so this gives us increased touch points, increased access to that provider. That's really beneficial. And for a provider, it's good for us too. More touch points is good. Make sure we get tests ordered, monitoring done, more timely treatment decisions. So those are things we all want as providers as well. And telemedicine has definitely been shown to have higher patient satisfaction scores. So higher quality of life, higher IBD knowledge, and even some benefit in things like ER visits. So, right, if you can meet with your provider more often, you can hopefully stay out of the emergency room. We're not necessarily seeing improvements in perhaps achieving remission earlier. It's really about that patient satisfaction and provider satisfaction and increased touch points that we see for telemedicine. Another thing to think about for remote monitoring is mobile-based apps. So a lot of patients want to be engaged in their healthcare, which is great. So how can we give ourselves an opportunity to allow that engagement and utilize that data for decision-making as well? And so one way to do that is apps. Apps will allow you to usually track symptoms, maybe track medication compliance, and then also incorporate things like educational modules or social forums to interact with other patients. And so as a provider, I can imagine a world where it would be nice to have that composite data of symptoms over months and see a graph, a line, how we're trending over time. Are we getting better? Are we seeing symptoms go down? Or are we seeing the opposite? Because that might flag me one way or another about making some treatment changes. And then I would say the one downside and things we need to work on is limited integration with our electronic medical records. So that's an area where we need to improve, which is how do we get that aggregate data to the provider to allow them to make decisions based on these apps. Okay. Wearable technology. This is an exciting thought. So it was mentioned by Aaron. A lot of us are going to have fitness bands, smartwatches, things like that. They track all these great measures, exercise, sleep, things that are really important to us. But those things are actually really good markers for disease as well. So we see that decreased physical activity, increased heart rate associate with active disease. And so can we actually use this data again in aggregate fashion to see how people are trending over time to make decisions as providers? This is a way we could think about incorporating data into our monitoring strategies. And also, we sweat under these bands. So can you use that to measure things like C-reactive protein or other inflammatory mediators? And there was some preliminary data, so you can actually measure things like C-reactive protein. So again, that would be nice where we could have non-invasive patient-centric data to incorporate into our decision monitoring strategies. Okay. Another way to think about it is home-based lab testing. So, you can do telemedicine from home, you can do infusions from home, but we don't really have labs from home. So you could imagine a world where it would be really nice to have labs done at home. It would be easier for compliance, it would be nicer for patients, and you could have more data points. In Europe, they're doing a lot of home fecal calprotectin. They have a really good system in place to be able to do that. We don't have that yet in the United States, but it would be really beneficial to allow ourselves to have calprotectin in a home environment and to be able to use those decisions to monitor patients. And so this is a nice picture because it kind of shows you what it looks like. It's very similar to maybe a COVID home test, pretty easy to use. So that's an exciting concept. We can move forward. And I think I'll have a couple minutes, so I'm gonna speed through the last part here, but you could also imagine a world where we could have blood testing, right? Nobody's going to be able to come draw blood from home, but think about how people get their blood sugars done. They can do finger sticks, right? And put it on a little strip, but then get it measured. There's been some research that has shown that those capillary levels of things like C-reactive protein and actually drug trough levels actually correlate pretty well with bloodstream levels. So wouldn't that be nice if we could do that at home as well and incorporate that into our monitoring strategies? Again, very patient-centric approaches. Bedside imaging. So this was a hot topic at Congress, had a whole session on it. And the idea here is that you can use ultrasound to actually see how changes in the intestine are happening in response to treatment. We see different things change, like the thickness of the wall. You can look for complications. And it's been shown to actually do a pretty good job of measuring treatment response early, even before symptoms. And so actually in Europe, they're using this a lot. And then in a couple US centers that are IBD specific, they're already having some providers who are integrating this into their practice. And it's nice because it's not invasive. There's no radiation. There's no bowel prep. It's not as expensive as things like colonoscopies or enterographies. But the limitations currently are that you need competency. So you need training, you need extensive training to be able to do that. So IBD providers have to commit to that training and set aside time. Institutions have to commit to that training and the cost of the equipment. So not universal yet, but something that is increasingly being recognized as beneficial and adopted by some US centers. So the last section is really just AI and machine learning. This is an entire talk in and of itself. So what I will just say is that machine learning and artificial intelligence is a hot area of research, across the globe in medicine and very specifically in IBD. So there's a lot of exciting things on the forefront of AI. I would say in the context of this talk about monitoring strategies, where it could be really beneficial is probably two areas. One is thinking about using all that data we have in the EMR, this unstructured data, to predict how people are going to do over time. So it might involve things like your demographic characteristics, your disease characteristics, your blood work, your endoscopy, and utilizing all that data to say, can we predict how this patient is going to do? Can we predict what treatment response they are going to have to give us a better idea of how to move forward and how to monitor patients? And also creating uniformity, how we measure across things like endoscopy and imaging in a uniform way, not just across providers, but across institutions more globally. So lots of exciting areas to think about for AI. Okay, so the summary points I would say are that disease monitoring is really important. It's meant to make sure that patients are doing well and prevent complications long term. We have good guidelines in place for how to monitor disease. We have some good tools in place, but there's always room to get better, always room to improve. And some of the things that we can think about are very patient-centric. At-home measurements that are easier for patients, clinician-directed point-of-care testing that can allow us to make more timely decisions. And then how do we think really in the future about integrating AI and machine learning into our monitoring strategies and individualizing that patient care? So I think that's it. That's my time. I'm going to thank you for all the dog lovers out there. These are my two dogs. So I'll pass it back on to, I think, Maggie.
Thank you so much for sharing about that. I just found it fascinating. I could listen to you for a very long time. But it was really interesting to hear about the importance of monitoring, to see disease progression and how effective the treatment is, but also what's really needed in the future. So thank you so much for sharing about that. And now I'm very pleased to introduce our next speaker, Dr. Anava Ren. Dr. Ren is a pediatric IBD psychologist and clinical assistant professor in the Division of Pediatric Gastroenterology at Stanford University Medical Center. Dr. Ren is also the director of the GI Psychosocial Services and IBD Celiac Psychological Health Programs. She has worked at Stanford's IBD Center for the past 7 years and has spearheaded the creation of multidisciplinary IBD clinical services and psychosocial research endeavors that provide more holistic IBD care to children and families. One area of her research is focused on exploring the use of novel mind-body interventions to support IBD symptom management and psychological well-being in children and young adults with IBD. She will present on one such intervention today, a mindfulness-based virtual reality intervention. Welcome, Dr. Ren.
Thanks so much, Maggie, for the introduction. I really appreciate it. I'm really happy to be here today to discuss the potential of virtual reality in IBD. So to start, I have no financial conflicts of interest to disclose. And for the objectives of my talk today, I want to focus first on providing an overview of virtual reality, and then really discussing the clinical potential of virtual reality, zooming in on IBD treatment, then moving into virtual reality research in IBD, and then ending with future directions in this area. So to start, I really want to make sure everyone has a clear understanding of what virtual reality is. So virtual reality is a computer-generated simulation of a 3D environment that makes a person feel that they are truly in that environment. This environment is created through virtual reality, or I will say VR, a VR app, and uses interactive devices. So in medicine, the most common interactive device is a headset, as you see in the picture on the right. And when the user puts on the headset, they can only see the VR content projected on that display screen. Can't see anything else around them, nothing in their periphery. However, the content really varies based on what app they're using. So one might be looking at a 360-degree video of a nature scene, or engaged in a game, or reading or interacting with educational material, or being guided through a relaxation exercise. But whatever the content, the VR headset or the device that you're using really creates this immersive experience that feels like the real world, or allows someone to feel like they're interacting with objects and events that are occurring that feel very real life. Thank you. So over the past decade, VR's presence in medicine has really grown significantly. And VR is most commonly used in these three areas of medicine: patient treatment, health education, and medical training. And when we think about patient treatment, VR is really used in many areas of medicine to improve clinical outcomes. But there are a few key areas where there's the most research supporting them. So that's surgery, pain management, physical therapy, rehabilitation, and mental health. And researchers are really currently trying to better understand how VR is able to improve all of these health outcomes. And still research going on here. It's not fully clear. However, there's been a lot of research within pain management, has some of the most research with VR. And in that area, when we're thinking about how VR reduces pain, it really appears to be through several key psychological mechanisms. So first, VR's ability to provide distraction. Second, VR's ability to create this illusion of time acceleration, where an event just feels shorter than it is. So a painful procedure feeling shorter than it actually is. And lastly, VR's ability to create this immersive environment where one can learn and practice self-regulation skills. So really thinking about learning coping skills to help one manage, feelings or emotions or behaviors differently and more effectively. So it's been hypothesized that really across different populations, it's VR's ability to distract and to create this immersive environment for skill development that leads to, or sort of is at the center of, why it might be so effective across populations. So more research is needed, but that's what's been shared so far. So when we think, as we've discussed VR generally in medicine, it's important to really think about its use and its potential in IBD. And pain really stands out as a primary area where VR could support IBD care. And when we think of pain in IBD populations, two main areas really stand out that could benefit from more support. So procedural pain and chronic pain. And when we consider procedural pain, individuals with IBD undergo regular procedures at the time of diagnosis and really throughout their IBD journey, throughout their IBD care, from blood draws to IVs to shots for tests or shots for treatment. And these medical procedures are often associated with pain and related procedural anxiety. So clinically, distraction is really most often used to support procedural pain. But however, growing research really supports VR's use in this setting. So if we look at the right here and what research shows, research has shown that VR really can improve pain across pediatric and adult populations. And in this area of research, you really see distraction as the main VR intervention. So, watching a video or playing a game. And while IBD was not the focus of this research, VR's ability to improve procedural pain across a diverse array of settings and populations really speak to its potential in IBD. And lastly, I will make one more point. In many pediatric hospitals like Stanford, where I work, VR is already present. VR is being used by Child Life Services, supporting individuals, children who have IBD. And they have shared, of course, at Stanford, but many other hospitals, how helpful it can be on a clinical side. So when we consider chronic pain, it's real. Of course, it's well known that chronic pain is a significant issue for a subset of individuals with IBD. And one of the most common clinical scenarios is persistent or chronic abdominal pain, even when IBD is remission. So this type of pain is really associated with many challenging and negative outcomes. So things like depression, anxiety, poor quality of life. And unfortunately, there's really limited treatment options to date and limited research in this area. However, some really exciting emerging work in another area of GI, so in disorders of gut-brain interaction, offer some support that VR might be quite helpful in treating chronic pain in our IBD populations. So briefly, some of this preliminary work has showed that VR can improve pain and other related outcomes in patients who have functional dyspepsia, functional constipation, and irritable bowel syndrome. So another area is mental health, and this stands out as a key area where VR could support IBD care, and particularly with supporting anxiety and depression. And when we think about anxiety and depression, it's well known that individuals with IBD are at increased risk for anxiety and depression. And anxiety and depression are associated with negative health outcomes from things such as less treatment adherence to increased risk of flares. And then these negative health outcomes are associated with increased emotional distress. And we really get this negative sort of vicious cycle that's created. And there's a very clear need that we need more mental health support for individuals with IBD. Since the pandemic, really this need has grown, and they're nationwide, but as well in our IBD populations, and there's not enough resources. So we're really in need of more accessible, more affordable options of care. And this is where VR really might hold great promise. And interestingly, on the right, which just popped up, recent research has shown that VR can improve anxiety and depression. So this work has been conducted mostly in adult populations, individuals with anxiety disorders, depression, eating disorders, PTSD or trauma, health populations, and pediatric populations undergoing medical procedures and surgery. And here, the VR intervention has been more therapy-based, so looking at exposure therapy or relaxation therapies compared to pain, which was more of the distraction-based interventions. And lastly, IBD, again, is not the focus of this research, but given that VR has been so helpful improving psychological outcomes, many different populations, many different settings, again, it speaks to its potential to really support patients with IBD and individuals with IBD. And there's been some preliminary work looking at mental health outcomes in IBD research, which I'll touch on in just a moment. Thank you. So currently, after we discuss these two main areas where VR could potentially support IBD patients, it's really important to review the current research. And currently, there's only been 3 published studies exploring the use of VR in IBD populations. In this first study, number 1 here, examined the use of VR during a pediatric IBD infusion to decrease medical trauma. And there was some preliminary promising findings, specifically that families found this type of intervention acceptable, felt like it could really help medical trauma in this setting, and specifically in its ability to distract from anxiety and pain in that setting. Secondly, looked at VR in vedolizumab infusion amongst adults, and this study also demonstrated some promising preliminary findings, such as individuals feeling increased feelings of well-being, relaxation, and generally more in control of their treatment. And lastly, this third study here is from our group at Stanford, which I'll go into more in depth about today for the last part of my talk. So our study examined a mindfulness-based virtual reality intervention for children and young adults with IBD. And our study goals were to look at how feasible and how acceptable this type of intervention was, a mindfulness-based virtual reality intervention. It is a bit of a mouthful, so I will start saying MBVR for short. And then secondly, to look at the impact of MBVR, mindfulness-based virtual reality intervention, on anxiety and pain. And we specifically looked at a mindfulness-based virtual reality intervention, as we were really interested in VR's ability to create this immersive environment where one could really learn and practice a self-regulation skill like mindfulness, which could be supportive across a range of settings for pediatric IBD populations. And mindfulness specifically was shown as there's really increasing research that demonstrates that mindfulness-based interventions can improve outcomes that are really relevant for an IBD population. So things like pain, emotional distress, inflammation, and increasing research that shows mindfulness-based interventions are effective, can improve health outcomes in chronic pain populations and in chronic illness populations, really across the lifespan, pediatric adult samples. Next slide, please. So given my time today, I will not go into all the details of my study, just briefly highlight that this study was conducted at Stanford Children's IBD Center in our outpatient clinic. We recruited patients from our clinic who had IBD, who were 10 years or older. Ultimately, we recruited 62 patients for this study. And after patients and parents filled out forms that gave their consent or their assent to participate in the study, they were brought into a private clinic room where they rated their level of anxiety and pain in the moment. And then they were fitted with a VR headset and experienced the 6-minute intervention, the MBVR intervention. And then following that intervention, they again ranked their level of anxiety and pain post-intervention, following the intervention, then completed a satisfaction questionnaire, and then engaged in a brief interview with one of our research assistants, research coordinators, to learn more about their experience with the intervention. So the whole study was about 15 to 30 minutes. And in terms of our actual intervention, MBVR, this application, it was a guided mindfulness recording that was synced with visual effects that were in VR and created specifically for this study. And the guided mindfulness practice was also written for the study. And the idea was to really bring individuals' attention, awareness to their present moment experiences. So to bring this to light, really in this intervention, participants were, their attention, their awareness was brought to their breath primarily in the natural environment. So you can see on top, there was a meadow with a waterfall. That was about half of the intervention. Then day turned to dusk to night, and they were in a northern lights scene. And individuals were encouraged to explore their surroundings using their senses, and then also following objects such as a butterfly going up and down, northern lights going in and out to help sync and slow their breath. Next slide. Thank you. So to answer the first aim of our study, we looked at how feasible and acceptable the intervention was. And given the rates of participants who signed up, completed the study, the feedback we received, it really appeared to be quite feasible. Also high levels of satisfaction. And we conducted these interviews to learn more about their experiences with MBVR and areas for future use. So you can see table 1 here shows that data, which we call qualitative data or qualitative feedback. And a few themes really came to life from those interviews. So the themes are listed on the left and then representative quotes on the right. And the main themes that popped up were that individuals found this intervention very relaxing, very enjoyable, really interested in using it across a range of IBD clinical settings, and then also a lot of interest in using it in their daily lives. Some representative quotes that I highlighted that stood out to me are sharing that they found it very soothing. They wish they had this technology when they were younger, helpful in the hospital or undergoing procedures, and also just helpful, sort of not related to IBD, but helping with managing stress and anxiety with exams or matches. Again, this was a pediatric sample. Next slide, please. Also important to highlight, there were no adverse events. Everyone completed the intervention, but during the interviews, one individual said that it felt a bit dizzy during the intervention, and another one did report feeling more anxious, but they did not drop out of the study. They did complete the intervention. Next slide, please. And in terms of our aim 2 and looking at the impact of the intervention on anxiety and pain, the data did show, our data analysis show that there was a significant decrease in anxiety and pain following the MBVR intervention. Next slide. So in conclusion, this is the first study that's looked at a mindfulness-based virtual reality intervention in children and young adults with IBD. And there's preliminary support to show that it was feasible and acceptable. And these findings really do support this idea and past research that VR could really offer a unique platform for mindfulness interventions, as they very actively capture someone's awareness in that virtual environment. And also that virtual reality really can be used as a creative, immersive environment to really learn and practice a new skill like mindfulness in our study. And some very preliminary support, of course, more research is needed, though, that this type of intervention, this intervention MBVR, can improve anxiety and pain among children and young adults with IBD in our outpatient medical setting. And strong interest in using MBVR in a range of IBD medical settings was a really exciting finding for us, and that was provided from that qualitative feedback. And people really felt that were in the study that MBVR could be helpful in a range of settings. So procedures, treatments, lab visits, hospitalizations to anxiety and pain management really could be valuable to multidisciplinary teams, as VR is very portable, very accessible if we're talking about headsets, easily in and out of the hospital, and can provide a lot of treatment and symptom relief and more holistic IBD care. And last slide, and given that I am running over time here, just the main things I want to hit home here are really in need. There's very preliminary support that IBD, this VR can be helpful in IBD populations, and a lot of potential for it clinically, but more research is needed on safety, on acceptability, feasibility, effectiveness. So here I'm just highlighting a few kind of future directions with research of more larger, diverse samples, pediatric, adult, looking at longer term use, comparing different types of VR on more outcomes. And we need more accessibility. We need more accessible and affordable headsets for everyone to incorporate into care. So really looking at insurance coverage. And lastly, just wanting to end with, if there's interest in VR after this talk, you're interested in trying it, it's quite accessible in many hospitals. And so asking child life services, patient care services, to try it out at your next procedure, if any point you're in the medical center, if they have it, and share your feedback with your providers, your teams, just to begin and continue conversations about VR supporting IBD, individuals who have IBD in IBD settings. So lastly, all of this just underscoring the importance of further examining VR interventions to support improved psychological and physical well-being in individuals who have IBD. So with that, just thanking my team and individuals who are part of our research and passing it back to Maggie for questions.
Thank you, Dr. Wren. As a former pediatric IBD patient and former nurse, I wish we had that. Wow, I wish I had that. So thank you again. Now let's bring all of our presenters back and we can take some questions from our audience. If you have a question for one of our panelists, please type it in the Q&A box, which you'll find at the lower part of your screen. We do have a question already, so this is going to be directed to Dr. Cushing-Dom. Let me scroll up here, sorry. See, okay, so this is an anonymous question regarding a patient experiencing belly pain and low energy, but whose labs and markers are looking good and bowel symptoms such as diarrhea are resolved. Would this be an example of symptomatic monitoring?
Yeah, I mean, so I think the main point I was trying to make is that symptoms and disease can be really well correlated in some patients, but then there are some patients where they're really discordant, and both ways. I have active symptoms, but everything looks good. I feel fine. Everything does not look good. And so what we do as providers is we say, okay, symptoms, again, are just part of this. So if the symptoms are ongoing, but all the objective data says the inflammation is clear, what else could be going on? There's a number of things: bacterial overgrowth, hypersensitivity, just a lot of different GI conditions that can actually be superimposed in IBD and can be treated accordingly. So we really think about those things. But you're absolutely right. That's an example of using all the data to make an assessment about what's going on with the IBD.
Thank you. The next question is for Dr. Wren. So VR is interesting. Is there any evidence that it assists with remission?
Yes, it's a great question. Currently, no, there is no evidence. There's truly just those 3 studies I highlighted, and it's possible that other individuals are conducting this research and have yet to publish it or share it widely at conferences. So no current evidence that it leads to remission. However, definitely with symptom management. So as I mentioned before, managing pain symptoms, managing emotional distress. That was sort of the more main outcome in all 3 of those studies, looking at psychological outcomes. And then given the brain-gut connection, there's absolutely potential that it could impact disease activity, but that research has not been conducted, but is a great area of future investigation.
Awesome, thank you. I just want to remind, if you have a question, please put it in the Q&A box. We'd love to take this opportunity to answer what we can. Let's see. I believe this question is about stress and anxiety. Can it cause IBD? For either of you.
Yeah, I'm happy to comment a little bit. So in terms of stress, anxiety is important in IBD. In terms of causing IBD, we do not think that stress or anxiety cause IBD. There's other things, there's genetics, there's your underlying microbiome. A lot of this, honestly, is still unknown, but it's probably a multitude of different factors. But stress and anxiety are important in flares of IBD. So while they may not cause IBD, they're really important to the course of IBD. I would say that, and I'll pass it over.
Yes, sorry, I was having trouble with that mute button, but absolutely, I couldn't agree more with Dr. Gushing that there's no evidence that it is a main cause of IBD, but can really exacerbate symptoms. So even if you are in remission, but can lead to other additional symptoms like pain. And there's definitely been research on contributing to flares and disease activity, but yes, not a primary cause.
Awesome, thank you. So to Dr. Wren, are you planning to study if VR could alleviate anxiety during flares?
Absolutely. So that sort of next steps of how we could use this, if we've received that qualitative feedback, those interviews were really valuable of how this could be helpful. And thinking of anxiety and how it contributes to absolutely flares, but also just quality of life, sort of across someone's life, how impactful anxiety can be, of how effective could this intervention be. So some of this future directions that I was mentioning at really looking at longer term use of VR is a really exciting next step. Our study was a 6-minute one-time intervention in an outpatient clinic, but looking at, what happens when you practice this daily for a month, right? How effective could this be at helping to sort of decrease anxiety, stress levels, and of course, how that can contribute to other IBD outcomes.
Awesome, thank you. I feel like I could pick both of your brains for hours. I want to know what's coming. So I think that is about all the time we have for this evening, at least for questions. Thank you so much for answering these questions from our patients, and for everyone joining today.
Yeah, so thank you all so much. Thanks to our presentation. So our program is coming to an end. That's all the time we have for today. So on behalf of the Crohn's and Colitis Foundation and the AGA, we encourage you to keep learning about IBD and to visit some of the helpful educational resources that they have available. So if you or someone you know is interested in being a patient reporter at next year's Crohn's and Colitis Congress, the applications are open. You can click on this QR code right here and apply. So also, I'd like to remind you all to please fill out the evaluation survey that will be sent to you after the program tonight. So we truly appreciate the feedback, and it does help us plan for future programming. Thank you for joining the IBD Insider Patient Education Program, and have a great rest of your evening. Thank you all so much.